Thanks very much for the invite. It's funny, I was listening to hearing about being dependent on medicines. I've been in bed with a heavy cold for the last 48 hours, which is why you haven't seen me around much. And taking 2 days of tablets is enough. So taking tablets every day for the rest of your life for something that you don't feel something for, like hypertension, I can imagine why patients don't take them. Half of them don't. There we go. That's interesting. So it won't advance. There we go. Apologies. Those are my conflicts of interest, which include working with Medtronic and Recall. Okay, so how do the devices work? So what it's trying to do is interrupt sympathetic activity. So about 20% of the total body sympathetic activity connects the kidneys and the brain and back again. And what does the sympathetic nervous system do? It's designed to make you run away from a tiger. If a tiger comes after you, it puts your heart rate up, your blood pressure up, it vasoconstricts, it diverts blood from passive organs into active organs. And all those things are great for running away, but they're not so good if they're left on. So I describe it as like driving around a car in first gear. We have gears in the UK. I'm not sure you have them in America, but that's where you put it into first gear. You get a very high rev, and if you keep driving around like that, it's not going to do you a lot of good. And that's what hypertension is essentially. So we are trying to reset an overactive sympathetic nervous system. That is a system that is wearing out a lot of your organs with vasoconstriction, left ventricular hypertrophy, renal ischemia, excess of renin causing salt and water retention, and hypertension. So this is how the graphic designers think that the devices work. So I'm going to focus on the two that have been approved. So on the left, you have the spiral device, which is a 4-point multipolar catheter, and it does quadrantic denervation for each of the electrodes, and it staggers them because in the beginning we thought that when we were doing RF onto the endothelium we might cause a fibrotic reaction and renal artery stenosis, but in fact we've not seen that, and I'll show you a little bit of data to support that. The ultrasound device is in the bottom right-hand corner. That's from Recall, the Paradise device, and that fires energy a little bit deeper, and therefore it only activates within the main renal artery, whereas the spiral device, you deliver into the branches, and I'll show you a little bit more on that in a second. So again, if humans were made of thermochromic gel, this is what would be happening inside you when you activate these devices. So on the left is the spiral device, and although these are staggered in distance, they create this hemiclove effect. And on the right, you see the ultrasound device there creating a little bit of sparing in the near field caused by water that circulates through the balloon during its activation. That cools the near field, protects the intima and the media, and fires the energy out into the periadventitial space where the nerves sit within the fat. And you get slightly deeper denervation with the ultrasound versus the RF device. But this is in reality what happens. And this explains a lot of why we do the techniques that we do. So at various points along the renal artery, we have these structures called heat sinks. Heat sinks absorb energy and attenuate the path and extent of energy that passes from each of your devices. So on the left, you see the baby Elvis character there. That is a single quadrantic denervation from a spiral device. And the renal vein that sits next to it, that is a heat sink. It will take the energy and it will dissipate it by carrying it away. The devices don't cause damage to these structures. They just cause attenuation of energy and limit the wave front. So you can't get beyond or around that. Similarly, lymph nodes do the same. And so the two devices have different characteristics, different patterns, but this idea that one goes to 4 millimeters depth, one goes to 6 millimeters depth, is just not true because we're not made of thermochromic gel. But you do get deeper penetration with ultrasound than you get with RF, and so the techniques have to be adapted accordingly. So do we denervate enough? Well, unfortunately, we can't sacrifice humans, so you tend to go to jail. So what we have to do is animal studies. And what we found is that if you just denervate the main artery only with a radiofrequency catheter, you get about a 71% drop in the neurotransmitter of the sympathetic nervous system, so that's norepinephrine. If you go into the branches where the nerves get closer and wrap around the arteries, and therefore are more within range for a radiofrequency device, you get about an 83% reduction. And if you do both the main artery and the branches, then you get a 92% reduction. Now, no one knows what the threshold is for neurotransmitter reduction required. Some people think it's 50%, some people think 70%. But with these techniques of comprehensive denervation that we did in the more recent trials, it's very likely that we're getting effective denervation. In fact, there's probably too much energy being delivered Because all we need to do is interrupt the nerves at one point along the length between the paraortic ganglia and the kidney. We only have to hit them once. The reason we're hitting them over and over again is in case of these heat sinks, this phenomenon like a lymph node or the renal vein or something else that can carry away the energy, and therefore we end up with a partial ablation at one point. So we try and hit them at multiple points along their length. Do they work? Professor Bart's given a nice summary. This is one from the recent article we wrote for the American Journal of Hypertension that just summarizes the 5 contemporary sham-controlled RCTs. And they're all pretty similar. Office blood pressures around 10, ambulatory around 6 to 8. I personally don't subtract the control arm because most of the blood pressure reduction in the control arm is protocol-mandated restarting of medicines. There's very little placebo effect, and that's demonstrated by the fact that these blood pressures that are achieved in the device arm, they don't go down, they don't regress. In fact, they get more potent over time, which again supports the fact that what you get in the treatment arm is what you get in your patient. So if you have mild to moderate hypertension, you get around a 10-point drop with both. So I think as far as efficacy goes, they both work. In the real world, you tend to treat more severe patients, and therefore you get a bigger drop. If you start with mild hypertension, you'll get mild drops. If you start with severe hypertension, you'll get large drops. So, and then there's this phenomenon that we used to think was statistical artifact, but in fact appears to be real, that the effect seems to get stronger over time. We've seen this now in at least 12 data sets. And I think it is real. What's probably happening is the permanent progression of hypertension that occurs with secondary remodeling is attenuated via this denervation process. We don't know for sure, but that's my theory, because we are seeing this over and over again throughout different data sets with different technologies. This is with the RF technology, and you can see it seems to be working in patients with diabetes, AF, CKD, even isolated systolic hypertension, which has been excluded from many of the clinical trials. And whether you're old or whether you've already got cardiovascular abnormalities, it seems to be working and working very impressively. This is this phenomenon again of progressive reductions in blood pressure. This is 3-year data. And then we've also got data out to 8 to 10 years with RF. And again, showing very impressive ambulatory blood pressure reductions. 1 millimeter of ambulatory blood pressure is more powerful than 1 millimeter of office blood pressure. And we've got medicines, it's not medicines. The blood pressure isn't coming down because they're being prescribed more meds. It's the other way around, they're coming off meds. This is for the ultrasound device. It's got less long-term data than the RF device. But here we have out to 36 months in Radiance Solo, again, durability of response. And then the longest we have for ultrasound is Achiever, 8 years, where the blood pressure is coming down and staying down. Although the volume of data with ultrasound at the long term is not as great as the volume with RF. With RF, we've done about 30,000 cases, and there's about 10,000 patients in the literature, and we've got data out to 10 years. With ultrasound, it's up to 1,000 in the literature, and we've not got as much long-term data. The only head-to-head that was done in a rigorous fashion with these devices is the radiosound study, where it compared RF in the main and the branches, and ultrasound. And the one that was weakest was RF in the main, but if you did the contemporary technique that was used in the spiral trials of main and branches, it produced similar results to that with ultrasound. This is a spiral distal trial suggesting that if you look at the anatomy here, the nerves start to coalesce around the branches. And so we're now testing this in the spiral SWIFT trial, whereby do we need to do this comprehensive strategy we did in the spiral off and on trials of 44 ablation points, that's 11 4-point denervations. Can we do a more targeted approach around the bifurcation point? And the early signal from distal is maybe that's all we need to do. That will make the procedure more efficient. Safety, 10,000 patient years of follow-up, extremely safe, very little incidence of renal artery stenosis, and renal function appears relatively unscathed. And that's with RF, and with URDN at 6 months, this is the meta-analysis showing, again, extremely high levels of safety, much better than the renal artery stenting data we saw from earlier. The equipment is 6 French compatible for RF and 7 French for ultrasound. I think with modern vascular access, that shouldn't be such an issue, that difference. The key difference is you do about 11 minutes of denervation with RF, and you do about 42 seconds of denervation with ultrasound. And so it's a more efficient procedure with ultrasound. But the trade-offs are the volume of data you have in the literature, the long-term safety outcomes versus the in-lab efficiency. You also have to exchange for different size balloons if you have different sized arteries with the ultrasound device. So yes, it's more efficient if you have simple anatomy, but the procedure times are not so different if you have to exchange balloons. The energy delivery is 1 minute for RF, and it's more like 7 seconds for ultrasound. Procedure, you go distal to proximal with each device in the branches for RF and in the main for the ultrasound. This is the ultrasound device here. You do have multiple renal arteries in many patients, 30%, and so you have to bear that in mind. You can treat everything between 3 and 8 with both devices, 3 and 8 millimeters, so you should be able to treat these now. When we left them behind, there was more failure of therapy. Big thing that you're going to be asked is cost effectiveness. So we published this in Europe for RF. It's a highly cost-effective device. You only have to drop 5 millimeters of mercury and you hit all the required standards of all the healthcare regulators in the world for cost effectiveness based on our projections. And in the real world, we're getting 3 times that blood pressure reduction. So in conclusion, you've got 2 devices that are approved. They both work well. They're both applicable to wide anatomies and patients. If you've got a short main, you might prefer the RF. If you've got a long main, you might go with the ultrasound. But really, they both work in almost all patients. They've got different volumes and duration of follow-up, and they've got different procedural characteristics. So the ultrasound is probably, at the moment, the more efficient procedure, but RF has got a greater body of data and longer-term follow-up. And therefore, you can go through with your patients, decide which device you want, and take it from there. Thanks very much.